Hello, this is Kathy Sokol again, and we're going to talk about part two of our clinical simulation day, getting busy. These are the clinical learning objectives for the course students who did the simulation. You will see that our simulation allows the student to meet each of these. The students and their clinical instructor reported to the simulation lab at 8 a.m. We changed the usual time from 7 a.m. to allow for last-minute setup. The day ran from 8 a.m. to 4:30 p.m. The group was met by me, the night nurse, who was going to give them a report on the 6 assigned patients. We used a bedside IS bar report. Students were given a brief overview of the patient's condition, similar to what they hear in the live hospital setting. I did not go over all the provider orders, just important ones they would be addressing during the shift. Same with the medication orders. The students were expected to review all the provider orders and the MAR once they had met their patient and performed an initial assessment. If there was a critical treatment or medication due right away, the student was informed about it. Things such as coverage for blood sugar or a change in drug titration were related to the student during report. The clinical simulation day was set up to mimic a typical hospital clinical day, with the exception that the students began their shift at 0800 instead of 0700. My role was to circulate and fill empty journals, add moulage as indicated, and relay complaints of pain or discomfort to the students from their patient. I also delivered meal trays and played pharmacy tech when needed. Ongoing documentation was completed throughout the shift. The clinical instructor reviewed the notes when it got closer to the end of the day. Any additions or corrections were completed before the debrief. All nursing students need a lot of practice administering medications. For liability reasons, healthcare facilities often place restrictions on which drugs and routes nursing students may administer. We built opportunities into the sim for students to experience a more realistic MedPass. Our students worked with high-risk drugs and were allowed to do IV pushes, in addition to the usual oral and topical drug routes. Another thing we did was to add at least one pharmacology challenge to each patient's drug orders. For instance, the student would have to titrate a heparin drip based on the APTT. IV flow rates were manually calculated before putting the drug on a pump. Compatibility challenges came up, requiring the student to critically think how to give the medication. If the patient had an NG or a G tube for drug administration, the student had to know which drugs were safe to crush. Students were expected to call a provider for a new drug order or to report an out-of-range lab value that might impact the safety of a medication. Each patient had a specific diet order. We took great pains to create trays to match those orders. Occasionally, a patient who is NPO would receive a tray, or a diabetic patient got a regular Coke instead of diet, to see if the student picked up on it. Students were expected to keep accurate diet and fluid intake records on all patients. Our trays were so realistic that the dean paid a visit one day and saw a soda can on the patient's table and reminded me that students were not allowed to eat or drink in the lab. I explained the soda belonged to the patient. All patients had a nursing treatment like Foley insertion, NG placement, or wound care. It gave students the chance to practice skills they didn't always do in the hospital. We didn't have a respiratory therapist, so students performed nebulizer treatments, taught the patient how to correctly use a multi-dose inhaler, and adjusted oxygen per the provider's orders. We used mannequins with audible lung sounds for our respiratory patients. These breath sounds could be modified as needed by the scenario. Students applied ice packs, elevated limbs to reduce swelling, practiced applying TED stockings and sequential compression devices, and sometimes applied braces or stabilizing devices. We could borrow equipment from the PT school on campus, so much of what they would see in the hospital would be available for the sim. Students reviewed their patient's electronic chart, which was loaded onto one of 6 desktops. All the charts were created from evidence-based clinical care and treatment. Websites like the NIH, CDC, and high-level teaching hospitals such as Johns Hopkins or Mass General provided a wealth of information for the health records. Color images, X-rays, EKGs, MRIs, and CTs might be included based on the SIM patient's diagnosis. The MAR, nursing assessment, and nurse's notes were all fillable. Other documents were locked so the student couldn't change them. New provider orders were handwritten and placed on the duplicate hard chart for that patient. A faculty member stood in for the provider when a student called. Students provided an ISBAR report, transcribed the new order, and then read it back. We felt it was important to give the students a chance to call for orders. Our state forbids students to contact a provider for orders, and the first opportunity to do so would be after graduation. During debrief, students reported on each patient. The group discussed any problems that arose and what the assigned student did about it. Each student was asked how they felt about the day. Simulation is a safe place, so students were encouraged to be honest about their feelings. If a student had a negative experience with SIM, their clinical faculty could work with them to address their concerns in private. Students shared one thing they intended to do differently if they were assigned a similar patient later on in the hospital. Comments included needing more practice doing an assessment or needing to work on organizational skills. A few needed more practice with basic nursing skills. There was a wide variety of responses when the students expressed their personal takeaway from the sim. Some found they were more confident than they thought. A few said they were amazed at how much work the RNs actually did during a shift. Seeing someone do the work is way different than doing it yourself. Many said they needed to spend way more time on pharmacology or reviewing medical terms. It was a lively and animated discussion for sure. To sum it up, no two clinical groups are alike. We repeated the same scenarios for many different groups with different responses each time. We found that students were very willing to pitch in when a classmate seemed overwhelmed to encourage them. Faculty had a new awareness of how students think and react. Post-SIM surveys revealed that students enjoyed the simulation, that they learned a lot. They appreciated the realism. They were grateful to have the chance to practice skills and decision-making they couldn't do in a live hospital setting. Students told us they felt more capable at the end of the day and more confident for the next time they went to a hospital. The faculty was also very excited about the clinical simulation day. Other instructors wanted to try it for themselves to address problems with a specific clinical group. Perhaps most importantly, clinical faculty reported better student performance in the hospital after a group had done the clinical simulation day. Hopefully, this gives you some food for thought. Think about how you can work a clinical simulation into your curriculum. If you can't take an entire day, can you set aside a morning or afternoon of clinical time? Even a few hours simulating a hospital setting will benefit your students more than you can imagine. Thank you for listening. Please feel free to contact me at sokolk2@gmail.com with questions and comments.